Hi guys, welcome. So this video is going to be a continuation from the previous video on visual pathways and the pupillary reflex. So we've kind of talked about the general anatomy and neuroscience behind the visual pathway in the previous video. This video is hopefully going to be a little bit quicker. We're going to focus more on some of the clinical applications of knowing what this pathway is. The cool thing about the visual pathway is that you can actually identify the position of lesions in the pathway based on the visual defects that present. So I would very highly recommend watching the previous video before this one, just so that this one makes a bit more sense. So I did briefly touch across this slide last time. I like to focus on 2, 3, and 4 in terms of these lesions here. So if you remember from the previous video, we were talking about so the optic nerve, the partial decussation at the chiasm, and then following the chiasm we have the tract. And then down here we have the radiations. The optic radiations, optic chiasm, optic tract. Before we'd start on some of the clinical things, there are a few terms I'm going to be using in this video that I'd like to just quickly define. So decussate or decussation refers to, it's basically the crossing over of fibers. And if I refer to an ipsilateral lesion or ipsilateral sign, that means on the same side. So for example, if I had a left lesion affecting the left eye, I'd say that that was an ipsilateral lesion to the defect. Conversely, we have contralateral, which means the opposite side. Cool. So let's start with a clean screen. So to start off with, if we have a lesion here in the optic nerve, what we're going to do is we're essentially cutting off all of the nervous supply of this eye. So all of the sensory information from this eye, all the light that's coming in sending signals, none of that is getting through to the processing centers of the brain. So effectively, those signals may as well not be coming through. You may as well have your eye closed. What we call that is a mononuclear blindness. So mononuclear means one eye. Blindness is obviously they can't see. So if we were looking through the patient's eyes, which is what these circles here represent, we would see nothing in the affected eye, and that's an ipsilateral lesion, right? So if we have the lesion in the left optic nerve, it's going to be affecting the left eye. If it was in the right optic nerve, affecting the right eye. Cool. So that one's pretty simple. The more interesting cases come when we start affecting at the optic chiasm and beyond. So at the optic chiasm, if you remember, that's where our nasal fibers decussate. So that's where the nasal fibers cross over, whereas the temporal fibers, they head ipsilaterally. The nasal fibers, I'll really explain this concept because it can be a bit tricky. The nasal fibers detect the temporal field of view, right? So this is our nose here. Well, this is a bird's eye view, by the way. So we've chopped off the top of someone's head. We're looking down on this. So left and right's the same as our left and right. This is the nose. So this is their nasal field of view. And then their temporal is out here. So the temporal field of view is detected by nasal fibers. And these nasal fibers run down, they cross over the optic chiasm. So what happens is if we knock out something in the optic chiasm, we're going to affect both nasal fibers, and so we're going to affect both temporal fields of view. So we get something that looks like this, where you've lost the temporal view in each eye. We call that a bitemporal hemianopia. So anopia means loss of vision. Hemi is obviously half, so you've lost half of your vision in each eye. Bitemporal means that we're affecting the temporal field of view on both sides. following on from that then, if we go to 4, so 4 here is in the optic tract, and this is the right optic tract, meaning that it's going to carry the right temporal fiber as well as the left nasal fiber. The right temporal fiber is going to be carrying the right eye's the right eye's nasal field of view, and the left nasal fiber is going to be carrying the left. Still gets me tongue tied. The left temporal field of view. So you can see that if we divide our eye in half, our left temporal is here, our right nasal is here. So we're essentially affecting the left field of view in each eyeball. What we call that, so we get a picture that looks a little bit like this. This has got a pretty cool name. This is called a homonymous hemianopia. So in this case, where we're affecting the left field of vision in each eye, this is a left homonymous hemianopia. And it's going to be affecting the contralateral optic tract. All right. So the visual defect it's a left field of view defect, but it's affecting our right optic tract. So we could say that's contralateral. So a few different things that can cause these kinds of presentations. If you remember from our previous video, we talked about some structures that are kind of running around the optic chiasm, which can result in a bitemporal hemianopia. So the optic chiasm has the internal carotid artery rising up on either side of it, and then directly underneath it, it has the pituitary gland. So if we get a tumor in our pituitary gland, such as a pituitary adenocarcinoma, that swelling can put pressure on the optic chiasm, and they will often present with a bitemporal hemianopia. They'll often, so really any kind of visual change like this, which points to a neurological cause, is going to get some brain imaging done, probably both a CT and an MRI. And if you're presenting with a bitemporal hemianopia, you're going to be really focusing in on the pituitary gland and having a good look to make sure there's not a cancer there. In both 2 and 4, multiple sclerosis, it can be a cause, which is a demyelinating disease, and we'll talk a little bit about that in a few minutes. Other possible causes are infarctions, hemorrhages, foreign body, depending on their clinical history, really. You'll notice that there's a few other visual defect patterns that are down here below. These are what we call quadranopias. So these were hemianopias, with hemi meaning half. Quadranopias are affecting a quadrant of the visual field. We won't go into those today. I guess out of interest though, if you get a infarct in your posterior cerebral artery, you'll often get what we call a macular sparing visual field. So maybe, I'm not a very good drawer, so I'll draw it on one of these instead. You actually get a similar kind of picture to a homonymous hemianopia, except the central vision, so it will be half a semicircle, will actually be spared. So this area will still have vision in it. And that's because the macula has dual blood supply, or the area in the brain that processes the macula has dual blood supply. So if we get an infarct back here in our posterior cerebral artery, then we'll see defects similar to a homonymous hemianopia, but with the maculas spared, because there were a separate blood supply will keep supplying the macular processing region. That's just a cool thing to keep in mind, I guess. So now what I'd like to do is chat a little bit about the pupil reflex, because this is pretty cool, and this is something that you can, rather than having a patient come in and saying that they have some visual changes, which can be a little bit hard to test, this is kind of one of the real doctoring things, I think, where you get to use a pen torch and you shine it in the patient's eyes and you look at how their their pupils responding. And obviously a patient's not really going to come into you and say, oh, I've noticed one of my pupils is shrinking a little less than the other. This is something that you pick up on your clinical exam. So we discussed this earlier. The light shines into the right eye, goes down the, it's detected by the intrinsic photosensitive ganglion cell, runs down with the optic nerve to the pretectal nucleus. It then sends off branches to both endovascular nuclei, so both the right and left, which sends a preganglionic parasympathetic fiber to the ciliary ganglion, and then a postganglionic fiber to the sphincter pupillae, causing the pupil to constrict. So, this is the pupil response. What I probably didn't touch on before is that this pupil reflex actually relies on two cranial nerves. The afferent nerve is, you might expect, the optic nerve, which is cranial nerve 2. So that's the one that takes information into the brain. The efferent nerve is the oculomotor, which is cranial nerve 3. And you might be wondering where that comes into it, but this endovascular nuclei, it's actually one of the nuclei associated with the oculomotor nerve. It's the parasympathetic nuclei of the oculomotor nerve. So that's where that comes in. So there are a few different lesions and patterns you can see with pupillary defects. So remember, if we're shining the light into the right eye, that constricts, that's our direct pupil response. When we shine it into this eye and this pupil constricts, that's our consensual pupillary response. So if we got the light shining into our eye here, but neither eye constricts, that gives us an indication that the lesion is somewhere along this along the optic nerve, affecting the intrinsic photosensitive ganglion cell, because there's no signal getting in that tells either pupil to constrict. We can also get something though where we shine the light into our right eye. The signal is detected by the IPGC, travels down the optic nerve, heads to the pretectal nucleus, branches go to both EW nuclei, but then if there's a lesion here, what we'll see is that the right eye won't constrict, so you won't get a direct pupillary response, but because the signal is still gone to the left side, you'll still get a left pupillary response, so you'll still get a consensual response. So this indicates that there's a lesion a little bit further up in the motor part of the reflex. Same thing goes if you shine the light in this side and this guy constricts, but your left side doesn't. So you have a direct response but no consensual, indicates that there's probably a lesion on the left side. And you check both pupils with the torch, so you'll notice that one eye will be affected and the other won't. Cool. What can be really cool though is this thing called a relative afferent pupillary defect. We detect that with a swinging torch test. And I've got a video of it here, so hopefully this will work. But basically what you see here, so focus on this eye here. See when the torch swings across, that pupil actually initially dilates rather than constricts. When it moves across, this eye constricts fine, but this eye will dilate instead of constricting when the light hits it. Okay. So that's called a relative, don't need to write it down, it says it here. Relative afferent pupillary defect. This test here is called the swinging light test, and that's what you use to pick up a RAPD, a relative afferent pupillary defect. Cool. So, what's happening there? This is common in diseases such as MS, which I mentioned before. MS is a demyelinating disease, and so what that does is that, as the name suggests, it destroys the myelin surrounding covering nerves. Myelin's really important for nerves to be able to transmit messages quickly. So you get a disruption and a slowing of the nerve signal from the eye to the pretectal nucleus. So what that means is that the message does eventually get there, just takes a really long time. And when you're doing the swinging test, so if we say we start in the right eye and say that this is a lesion affecting the right optic nerve, we swing from the right to the left eye. The left eye constricts fine. The right eye constricts fine. The right pupil constricts fine. When the light's swinging in between, there's a moment where both pupils are in darkness, and so they'll start to dilate again. When the torch hits the right eye, because there's a slowness and a decreased velocity of transmission here, instead of the pupil immediately constricting, as you'll see in the left eye, it actually is continuing its dilation that started in the swinging from right to left. And so if you kept the light on there long enough, it should eventually shrink back down. But in the swinging light test, because you're moving the light quite rapidly, you'll notice that every time you switch to the right eye, the pupil, instead of constricting like you would expect, it actually dilates because there's a delayed effect. The light has a delayed effect. When you switch back to the left eye you'll see rapidly constrict again. And every time you bring it back to the right, it will take a long time for the right pupil to constrict, and it'll have that paradoxical dilation when you would expect constriction. So knowing that, I'll just keep showing you a bit more of the video. So again, see how there's that paradoxical dilation of the pupil rather than the constriction that you would expect. Now, as I say, this is very common. This is a very common finding in multiple sclerosis, where you get decreased velocity of transmission. Well, that's all for tonight. Thank you guys for watching. As always, if you have any feedback, I'd love to hear it. Please leave it in the comments below or send me a message. If there's anything that you'd like me to cover as well, I'd love to hear it. Thanks guys, thanks for watching, and please remember to subscribe.